What is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
What's up, everybody? Dr. Zach Baker here, and I have got Christian Huckfeldt, our Frederick location sports resident, on with us today. This is part of our monthly research journal article review, and these journal articles follow the theme of our sports residency, which in the month of January is the hip. And when we finish up with these recordings, we send it out to the staff, and this is reviewed by them and then discussed in our in-services the following week. So recent transition that we made with our monthly in-service routine. I'm excited to see how this is going to play out the rest of the calendar year. But it's been well received so far, and hard to believe that it's getting to be the end of January. The last time we recorded this was right before the holidays. And Christian, man, did you get anything good over the holidays? Travel a little bit?
Yep, definitely did a lot of traveling. Did I get into anything good? Probably not. Probably ate way too many cookies and way too much food. Still kind of recovering from that one. You're
a Philly kid. I don't think good's in your vocabulary.
Yeah, probably not much.
So, Christian, talk to us a little bit just about, we had the January, the theme of the month is the hip. So what was the article that you chose, and why did it stick out to you?
Yeah, so the article I chose was called The Associations Between Initial Clinical Exam and Imaging Findings and Return to Sport in Male Athletes with Acute Adductor Injuries. So recently I've had a couple of adductor injuries that have popped up on my caseload, so I figured this would be a pretty good idea to determine, or at least to look into and see if there's any changes with return to sport in terms of timelines.
Awesome. Adductor injuries are ones that we learn them in PT school. We see them in the clinic. We just tend to not see them with as high of a frequency as some of your other injuries that you see in the clinic. And I think when you talk about the different activities that you would commonly do in the gym, if you think about a regular strength training routine that just the general population's going through, there's not a lot of things that you think about that are direct adductor loading. So I think from a clinical standpoint, it can often be difficult to figure out what's our entry point, how do we progress exercises. If you don't routinely do adductor strengthening or mobility work, you may not even have a really good feel for what's normal in regards to the sensation that you feel, where you feel things, what are common compensatory motions. So I think one thing that I would encourage all clinicians, especially earlier on in their career, is get into the research, get into the weeds a little bit with adductor rehab, one from a diagnostic standpoint and just being very comfortable about being able to differentiate what is a true adductor injury or maybe an isolated adductor injury versus something that may be more lower abdominal or maybe it's more intra-articular with the hip and it's just referring to that area. But it's a very busy area, and I think diagnostics are important to get comfortable with. But then once you can accurately diagnose, intervening on them can be a little bit tricky if you don't have a good grasp of exercise progression with that. So, Christian, with this article, with the study, how was it designed? How was it set up? What were they really intending to find with it?
Yeah, absolutely. Well, first of all, Zach, that was a pretty good soapbox right there. I do like that one. So the study really looked at 81 athletes who were pretty high level. They were either the highest level or second highest level in their national league for soccer, futsal. You ever seen that sport, futsal?
I have, and it's one that I know I would not be good at.
So, yeah, soccer, futsal, volleyball, and basketball mostly. About 60% of them were soccer players. So they took individuals with an acute adductor injury within 7 days, and they brought them into the clinic. And what the therapist did is they performed a typical, what you would see in a normal outpatient clinic, clinical examination. So they looked at resisted hip flexion, resisted hip adduction at different angles and different ranges of motion. It took range of motion measurements, most specifically in abduction and extension. They palpated, they did a few special tests, and kind of got an idea of where they were clinically, what you would normally see on a clinical exam. And then they sent them over and they got an MRI to look at the severity and the location of the adductor injury. So that was sort of the beginning part. And then what they did is they sent all these individuals to physical therapy. The cool part about this article is this research group actually published a study earlier in the year that was kind of a criteria-based progression for adductor rehab. So they used their own progression that they had used there in the study. Individuals actually went to PT 5 days a week, so it was a high volume. And really all they did is they tracked each individual and identified the amount of time, or basically number of days, until they were clinically pain-free, until they started doing more sport-specific type training, and until they returned to sport. And so with that, they went back retrospectively and kind of looked at their initial clinical exam and MRI findings and saw if that had any impact on the amount of time until return to sport.
That's cool. And that's awesome that you'd mentioned this same group had done more of an intervention-based protocol research earlier, because I think whenever somebody in the PT field reads an article about, this low back pain or shoulder injury or ACL injury, and they say, they went to PT, everybody's first response is, what'd they do? Or I would have done something different. And I think this just helps some validation in regards to the actual PT that was being performed is something that's already been tested, researched, and proven to be effective.
Yeah, exactly. E3 Rehab actually used this study protocol in one of their adductor articles and just kind of blog posts. It's a pretty good article. I think we can probably link it in the show notes as well, and it does a pretty good job with a systematic progression of a loading perspective, which is something that obviously is super important for these types of injuries.
And then you had also mentioned the high volume and high frequency of which they were getting care. And I think, that's appropriate for the population that they're with. And this is the population of athletes that are going to have access, most likely, to that type of frequency. They can pop into their training room. They probably have PTs, strength conditioning members on staff that are with them routinely. And I think a big takeaway from that is, and we'll get into the results of this study, but I think it highlights the importance in an outpatient world of, if you only have 1, 2, maybe 3 touch points a week with an individual, thinking about how they can allocate efforts from a home exercise program outside of their clinical time is very, very important.
Yeah.
That's kind of a good segue, Christian. Do you mind talking, what were the actual results that they found within the study, the conclusions that they came to, and then if you want to add just any of your personal thoughts to it.
Yeah, absolutely. So in terms of the clinical exam, like the physical therapy exam, they found 2 predictors that were kind of resulted in the longer return to sport. The first one was pain with palpation up in the proximal adductor longus insertion. And then second was a palpable defect. So they kind of go hand in hand, really just pain up in the insertional part of the adductor longus, and then if there was a significant defect that was able to be palpated. In terms of the MRI result, the most important predictor for longer return to sport was injury at the bone-tendon junction. So really that clinical exam and MRI report kind of go hand in hand. And they really found that the most severe injuries were isolated or mixed proximal adductor longer injuries up at that bone-tendon junction, and also where the palpable defect was found there. The interesting part was that if one of those 3 criteria was positive, the return to sport was about 4 to 11 weeks, which is kind of a big range, honestly, for those individuals, versus if none of them were present, the return to sport was somewhere around 2 to 4 weeks. So, I thought that was pretty significant. And the other part that I thought was pretty interesting is that the remaining clinical variables that they looked at during the eval, so resisted hip flexion, adduction, all those range of motion measurements, all of those special tests that I think school puts a lot of validity into, all of those combined only accounted for about 25 to 30% of the variability in terms of return to sport. So I think it's really significant, and this study does a good job at showing that clinically, I think, first of all, we kind of need to screen out for these proximal adductor injuries, especially the avulsions. So do they have significant amounts of pain at the proximal insertion? Is there a significant palpable defect? Those people are probably people that we need to educate that return to sport's going to be a little bit longer, but also those might be the individuals that may need an appropriate referral out for imaging at that point as well.
And it's interesting that you bring that up, because recently had Bami on here talking about hamstring injuries, and one of the inclusion criteria for the hamstring strains was the presence of palpable tenderness within the hamstring, and that's been found to be a predictor of success or lack of success with returning to sport following hamstring strains. And it just goes back down that same road of, don't be afraid to put your hands on the patient following an injury. And I think we go oftentimes very far into the weeds with movement-based assessments, and we look very globally, we look very tunnel vision, but sometimes we forget to simply just palpate and get a real clear picture of identifying where they are palpably tender. Is it muscle belly? Is it tendon? Is it bony insertion? And I think not necessarily from a diagnostic standpoint, but with serial testing and seeing, is this changing for the better or for the worse? Is this changing with exercise? Is the things that we're giving them from a mobility, a strengthening, a reconditioning standpoint, is it making that palpable tenderness better? Is it making it worse? Or is it not having any change? And then how does that relate to all of your other functional metrics that you're tracking as well?
Yeah, absolutely. And I don't want it to seem that I'm saying not to do those special tests or not to do the resisted motions and range of motion. I think those are super important to guide you as the initial plan of care. I just think it's important to recognize maybe the limitations in terms of the ability to predict the return to sport timeline, if that makes sense.
Absolutely, and it's a recipe. When we think about diagnostics, when we think about monitoring progressions within a plan of care, and then ultimately your return to play decision making, it's a recipe, and you're trying to figure out for every injury, you put more or less stock into different parts of that recipe. You know, for some injuries, range of motion is a little bit more important. For others, strength is a little bit more important. For other, the palpation is a little bit more important. I think in this study, it just does highlight that they are all important, but we need to make sure we're not being negligent of that palpation piece with it. Now, I also thought that the return to play timeframes were interesting as well, where you'd mentioned 4 to 11 weeks versus 2 to 4 weeks. Yep. And I think that's something where, especially with the adductor complex, because you have a group of adductors, it can be easy to mask some deficiencies, even if they do have structural damage to one of the muscles. So they may be able to hide some of their strength deficiencies with manual muscle testing. They may be super compensators, and they may just be very coordinated and fluid with their movements, where when you're doing your more field or court-oriented tasks, and these were field and court-oriented athletes, which makes sense for an adductor strain. The more lateral rotational movement you're going to have, the more likely you are to stress that area compared to maybe like a cyclist or a marathon runner that just has a low impact but high repetition sagittal plane activity. Or if they are having an adductor injury, it's probably much different in etiology than some of these acute strains that they're experiencing. But that was also just kind of, I don't want to say shocking, but highlighting to me the variance that you can have. And I think that goes hand in hand from an early stage communication to the patient of, we know that we should trend in a positive direction. We know the sequence of events that should happen, but the amount of time that we are spending in each phase of rehab, or the amount of time it takes to progress through that sequence, is going to be dependent upon how you're tolerating activities and what types of physical competencies you're demonstrating, which then goes hand in hand back to what are we actually using as our metrics for progression. Now, Christian, personally, with adductor rehab, are there any staples in your program that you like to include from an exercise standpoint? Whether if you have any just early phase that you like to, or mid phase, but what are common things that you find yourself utilizing in adductor strain rehab?
Yeah, absolutely. I think in any muscular rehab or rehab of a muscle strain, I think it's important to try to load the affected tissue early in the rehab process while being considerate of the tissue healing timelines and maybe the amount of structural damage. So I tend to like more slider variations. Can start long lever or short lever, probably short lever. Can start partial ranges of motion and then progress to longer ranges of motion. I've found, at least initially in adductor rehab, Copenhagen's are great, but they may not be tolerated as well earlier. So even that's probably more of like a mid-stage for me. Those are probably two of the staples, I would say. I think another important thing to consider is that the adductors, especially depending on what muscle we're talking about, have an action on hip flexion and extension as well. So even if they can't tolerate direct adductor loading, can they tolerate split squat isos to certain depth? Can they tolerate bridging or some sort of hip extension-based activity to a certain depth based on their tolerance. That may even be a fine entry point until they can tolerate more isolated loading.
Yeah, and I think we're all familiar with the Copenhagen progression, and I can personally attest to having multiple patients where if you tried to do that with them early on, their eyes would jump out of their head and they'd say, there's no way I'm getting in that position. So sometimes just as simple as, just a hook lying adductor squeeze is fine. And then also with that flexion and extension component with the adductor group, you can also get creative with just various straight leg raise positions where maybe we bias them into IR or ER and have them flex or extend, and you just put that adductor muscle group in a more direct line of pull with the action of hip flexion or extension as well. So I think there's a lot of ways you can get creative early. I love slider progressions like you had mentioned, whether you're in like a quadruped position and you have the slider under the knee and you're going in and out that direction, or if you are in an actual standing position. There's a lot of easy and simple and practical ways to load the adductor groups early on. And I think the key is loading them early on and just monitoring tolerance and acceptance to that. So, Christian, I appreciate you, again, doing the dirty work for us and going into the research, relaying to us and making some good practical conclusions. Next month will be February, and we will be going into the spine. So I don't know if you're going low back, cervical, T-spine, what route you'll go with that. But I'm excited to have you and Bami back on here and just relaying what you find. So appreciate your time, Christian.
Yeah, thanks so much for having me.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.